So chronic pain is a very interesting problem and a very difficult problem to treat. So a little bit of background of the history of the development of pain as a specialty. And many years ago, pain was considered as a symptom of a disease. And it was the symptom of other diseases. And once you treated the underlying problem, usually the pain hopefully would go away. As the years have gone by, it became clear that chronic pain and that it was not acute pain that would last for a long period of time, that chronic pain was an issue in and of itself. An example being, if someone had a heart attack, that was a pain they would get in their chest secondary to an underlying problem within the heart itself. And once you solve the problem, the pain would go away. So pain, as a symptom, we know, as it tells us there's something wrong with the body, and it also advises that something needs to be done. However, as time went on, it became clear that the causation of pain to an organ was due to a pain system in and of itself. Example being that there were nerves that supply these different organs that warn you that there's pain. No one ever thought that the pain of these organs was not only necessarily due to the organ itself, but that the nerves themselves that supply these organs and tell us that there's pain might have become damaged with themselves. And that is where we stand when we look at pain today. We realize that there is pain secondary to damage of organs, there's pain secondary to disease, but there is disease of the actual pain system itself. It usually starts off as a secondary phenomena from some problem or insult to that system. But once the system becomes damaged, it can cause a problem in and of itself within that system. So that is really the development of the chronic pain. Acute pain being the pain you feel immediately as a response to an initiating problem. And when the pain continues despite the problem going away, that is what we know now is the development of chronic pain. And I emphasize that chronic pain is not acute pain that lasts. Chronic pain is an abnormality of the pain system. The development of chronic pain in a patient is multifactorial, meaning that there are many factors that can lead one person to get chronic pain versus another person that doesn't get chronic pain. I think the issue is that many people will get chronic pain the same way as someone may get a heart attack. You can have two people in a room that both had a heart attack, and how they respond to that heart attack is certainly different. The underlying problem may be the same, but how we respond to that underlying problem is the question that one needs to understand. So my starting point would be always that there's a chronic pain develops in certain types of people, but it also develops in response to an actual trauma, and two people may respond differently to the same problem. So I think we mustn't confuse whether chronic pain exists versus the response of one person versus the response of another. It's like saying, well, the guy does not have a heart attack, does not have a blocked artery because he doesn't respond in a certain way to the pain of, say, a heart attack. So the chronic pain is a definite pathology, which is the same, I believe, in everyone. The response to that pain may be different, but certainly the underlying problem remains the same, in my opinion. Up until recently, as I was saying, the understanding of chronic pain was not clear. It was not clear why one would suffer with an ongoing pain. And even today, there are many people in the medical profession who don't understand the underlying pathology, meaning the underlying damage that may go on in a person that's, for a good example, traumatized by a motor vehicle accident. Just use that as an example of a direct trauma. When someone is in a motor vehicle accident, they may get rear-ended. There is damage to certain parts of the body, usually the cervical spine or the lumbar spine, and someone may suffer after that ongoing pain. To the uninitiated, to the person who doesn't understand what the causation of that pain will be, they would say that it's psychological and that the pain isn't real. Up until a number of years ago, there was no way of proving that that wasn't true. However, we now know that there are pain-sensitive structures in the spine that can be damaged. And the pathways have been elucidated and they have been shown. And we know now that there is actual pathology, meaning there is actual damage to nerve fibers at the time of a motor vehicle accident. And that is consistent with damage to the nervous system. So I think that is where the big problem is, that you would have a heart attack patient who would be depressed, anxious, suicidal. Suicide is high amongst that population, yet no one states that they are malingering or no one states that they are crazy. Put the same hat on to a chronic pain patient and no one thinks of the pathology, which is the damage to the structures. They just think of how the person has responded. The reason being is that there is an unawareness, even amongst the medical profession, of the actual underlying pathology and damage that's going on to the nervous system. A good example is, and a lot of people understand this, is when someone has shingles, which is a herpetic lesion, and you see it on TV, you see the redness. When that goes away, there is no sign of any damage, yet the patient continues to suffer with ongoing severe pain. No one then questions that situation, and in fact they did up until recently say it was all in their head. And we have to, as a population, start realizing that this is a very serious, physically pathological disease in and of itself, like any other disease. And it is not a response to a pain. The pain is ongoing from underlying pathology. To not believe someone that's telling you something is wrong with them is unethical. So starting at that point, one has to believe them from the beginning. We don't go into a situation as a doctor saying there is nothing wrong with you and you're lying to us and prove it. It's not a court case where they have to prove to us their illness. It's up to us to believe them. And that is an ethical, very big ethical issue, which has to be taken very seriously. So when there was no evidence, or where we did not have the knowledge we have today of many diseases, we didn't go around and not believe them. Otherwise, there would never have been any progress. We believed the patient, and based on the belief and on what the patient was telling us, we were able to develop medicine. And as time went on, the more information we got, the more we were able to seek out what was going on. The pain field was mired in lack of interventions, lack of belief. Why? Because it's a long discussion. That pain is an emotional, it's psychological, how people respond to it, how we respond to patients who have pain, and how a caregiver responds to a patient with pain. There is an interaction of our own feelings regarding this. So it's very emotional, the whole area. But if you stand back from the emotion, which the researchers did, we began to realize, again, that there was underlying real pathology that was causing people to have their pain. And this is seen really a lot in neuropathic pain, in sciatic pain, in pain where there's damage to nerves. No one questions this. It's where you don't see it is the problem. A good example is migraine. You cannot diagnose migraine except clinically. The patient could be lying to you. You cannot diagnose many of the psychiatric illnesses. I mean, if you look at the DSM-5 and the 4, really all they are descriptors. Someone walks into a room and says, I don't feel well, I feel depressed. And we believe them based on crazy criteria. It is such a non-scientific approach. But I like it because it's an ethical approach. At least we believe the patient. In pain, there is less belief, yet we have more knowledge of the pathophysiology of certain disease and pain disorders. The point being that we know there is real pain and we know there is real underlying pathology in many pain patients. Going back to the motor vehicle accident patient, many of the symptoms that are given to a pain physician who has knowledge actually are quite consistent with what one would expect with the underlying pathology. So I look at pain the same way today that there is an underlying pathology, there is symptoms that are given by a patient, and unfortunately the medical profession and the paramedical profession are not recognizing those symptoms, which is a very big tragedy. I'll give you one example where we know the underlying problem, where we do not question it from the point of view of what we understand. And an example of this is an area which is a complaint called cervicogenic headaches. These are headaches that come from the neck and cause headaches post-trauma. When I got into the pain field nearly 25 years ago, no one believed there was any major connection between the neck and the head. Obviously, there's a very big connection between necks and heads. They usually go together, but not a connection from a pathology perspective when it came to patients' symptomatology after, say, a motor vehicle accident. Over the years, due to the work of Bogduck in Australia, we were able to find out what the causation of pain was. The pathways were elucidated, and it became clear that there was a direct connection between the peripheral injury in the spine, the spinal cord, and the brain. And that connection was damaged at the time of a motor vehicle accident, causing the persistence of chronic pain, usually with headaches, either on one side or the other side of the head. With that knowledge, we were then able to develop treatments that were able to help patients. And unfortunately, I say it again, there are many, many patients out there. I would say the majority of patients are still being treated as if they have a muscle ache and pain, as if their physiotherapy is going to make them better. And I'm telling you today, they will not get better because the interventions are inappropriate. We have to educate the medical profession regarding this area. And when someone comes in who complains of this from a motor vehicle accident, then it is like diagnosing anything. You either have a doctor who can diagnose chest pain, decide it's cardiac, decide what to do, and do it. There's no difference with someone walking into your office who's got neck pain 6 weeks after a motor vehicle accident, who tells you that the pain is referring into his head, that tells you it's referring into his shoulder, is consistent with actually landmarked investigations that are found in many spinal textbooks, and they should be treated appropriately. So it is not difficult for the initiated to understand these patients and believe them because the pathology is there. If you don't know, you don't want to admit you don't know, and you therefore treat with your prior knowledge. Education is really a big problem across the board. We see a big push in other areas of medicine, and a lot of resources go to the fancy and, to use the famous sexy word, when it comes to certain diseases. And that's because the powers that be, the patients, the advocates, have taken up the cause. Now, obviously, the more the disease affects the public, the more money is put into it, the more research. Unfortunately, what chronic pain does to many families is it destroys the fabric of the family, it causes breakups, and it also causes a patient to not be able to work and not have funds. So the spiraling down of a chronic pain patient is not unlike the spiraling down of a mentally ill patient. So when you get this spiral, it's not like heart disease where you get a little bit better, you go on your drugs, but you can work. Chronic pain, unfortunately, because of the fact that it is there all the time, actually affects one's capability of functioning in society. A diabetic patient may not even know he has got diabetes until his leg falls off. Or he may not know he has diabetes until someone tells him. Pain lives with you from day one. You wake with it, you sleep with it, it becomes your partner. And it stops you from actually doing something. If you have a pain in your back and you try to get out of a car, or you try to have intimacy, or you try to go and play with your children, it affects all aspects of your life. So pain is very pervasive, and it also brings down the person. So they can't fight for what they need. No one wants to fight for them because the persons that are most affected are the family, and the family hates them for this. So it is a very horrible disease once it takes hold. Acute pain is not chronic pain, and chronic pain is not acute pain. Acute pain is something that has a different mechanism, has a different ending in some cases than chronic pain. So it's very important to realize that chronic pain is not acute pain that lasts. Chronic pain is a different pain. It's a different underlying problem. It's a different underlying pathology. Keeping that in mind, when someone has a motor vehicle accident, for simplicity, the neck gets shaken back and forth and damage to the pain-sensitive structures take place. Those structures are the discs, the capsules of the joints of the neck, and the nerve supplying those areas is what tells someone they've got acute pain. If I take my finger and I bend my finger back, at a certain point, it hurts. It's the same thing in a motor vehicle accident. It hurts. Now, if you go back too far, it really starts to hurt more than it should hurt, and it doesn't settle down in 2 days. It starts taking a bit longer. The reason for this is that the nerve gets injured, inflammation takes place, and the nerve does what it's supposed to do, tell you to rest, tell you to not move it, to allow it to settle down. However, in a proportion of patients, that does not happen. But the inflammation continues to occur. The nerves are then basked in this inflammatory, we call it soup, and the nerve itself starts getting damaged. I would venture, at the risk of being outspoken, that many of the caregivers that are treating the patients in the acute phase are not aware of what the true underlying pathology is. And most physical therapists, again, I'm not getting at the physical therapists, but I would say most family doctors too, and most physicians were not aware of the underlying problem that is going on until it's too late. That's why you've got chronicity. Now, the question could be asked, so Dr. Jacobs, you have the answer to the chronic field in whiplash. I would say that I don't have the answer, but I would say that we have a long way to go to where we are from today. And we're not using the knowledge that we have today that we should be using in order to treat these patients. And that is a big problem. The problem, therefore, is that we know enough right now to give the services to these patients, but the inappropriate treatment is being given, I would suggest. You see many clinics and insurance companies who do not support the initial treatment of these patients in an appropriate fashion. And if all the parties were to get together and to learn about what is actually going on, like we do in everything in medicine, I believe that we would have a far better outcomes to chronic pain across the board. Now, I spoke about about motor vehicle accident, but you can also put on the rheumatological cap. People have rheumatoid arthritis. They don't get treated for their pain until way into the disease. The immunosuppressive drugs work, but they don't always stop the actual damage to the pain fibers. And you can have patients whose rheumatoid arthritis is actually burnt out, where they actually no longer have active disease and they suffer with terrible pain. And that is because, as I said earlier, the system, the pain system, the nerves, the nociceptors, the pain fibers have been damaged by the chronicity of the problem. So it's a huge area of misunderstanding by the public, by the medical profession, about what is actually going on. And many of these physicians will not treat these patients because they don't know how to. and they don't want to get involved with the appropriate medication that may be necessary for these patients. So it is a huge problem, and that's why we have this problem. The treatment of chronic pain, as I just discussed, is multifactorial. But always, as in everything in medicine, you have to make a diagnosis. That's the problem. Again, I will say there are many people out there who treat chronic pain who wouldn't know or don't know what they're diagnosing or what they're treating. What they're saying is, it is musculoskeletal. That is like saying it's your body. It doesn't mean anything. We have to be more specific. We have to know what we're treating. And we have the knowledge now to do it. There is no excuse to say, I'm treating, muscle pain, when someone's been treating the patient for 10 years and it's muscle. It just doesn't make any sense. So you have to make the appropriate diagnosis. So you need that part of the team to treat that problem. Like in cardiac disease, you've got a multidisciplinary group. In diabetes, you have psychology, you've got occupational therapy, you've got dietitian. Put on the same standards for chronic pain. Don't change it. Every disease we know requires multidisciplinary approaches. Don't pick on pain as the bad apple. That's what I advise people who are dealing with this issue and who are trying to come to grips with this issue. It's time that pain gets the same respect as any other disease. It is the cause of most disabilities. The amount of money spent on disability far outweighs the cost of cardiac disease and diabetes even combined. There is a organization called the International Association for the Study of Pain. They brought out a diagnostic manual many years ago. How many people use it? How many people even look at it? Everything, as they say, if all you have is a hammer, everything is a nail. And that is the problem. So the treatment is multidisciplinary. That means not just a word. It means that you actually look into what the areas of where there are problems, and you treat those problems as a cohesive group. Now, specifically, my area is the treatment of the medical aspect of this problem, and the ideal is to treat it as a team. I'm not a psychologist, and I'm not an occupational therapist, and I'm not a physiotherapist. And I realize the importance of them as part of a team. The problem is that in our society with chronic pain, the physiotherapist is treating and no one else is. Or the doctor is treating and no one else is. So you have a car like 4 wheels and 3 wheels are missing. It becomes a bumpy ride. You need 4 wheels on the car. And those 4 wheels have to run together with the engine in the front. That makes for the smooth ride. The medical management, unfortunately, is many times inappropriate. So you've got 3 wheels on the car, and the 1 wheel missing is the medical wheel. So let's talk about the medical wheel missing. The medical wheel missing gives a very bumpy ride in this condition. Why? Because no one would ever say you should treat cardiac disease with psychology, occupational therapy, physiotherapy, and say they shouldn't take the medications. Who would say that? Only a very ignorant person, and a person would lose their license for it. I do not believe there is any difference with the chronic pain patient. There is no difference, actually, between the chronic pain patient and the cardiac patient. And yet our society looks at them differently. Again, that is another tape. That is another question. That is another hour. But from the point of view of the treatment, we know there are medications that work. We know that there are interventions that work. Now, there are the naysayers out there who would say, you haven't got the proof, you haven't got this, you haven't got that. I would answer to them that in many areas of medicine, we do not have the proof or the double-blind study. And again, that is another topic. I will venture to say that even with evidence-based medicine, the treatment of the expert, medicine recognizes experience, medicine recognizes what the patient is saying. And if a patient tells you that he's getting better on it with a certain intervention that is based on good medicine, where colleagues in the same field agree, then it behoves those that don't understand it to learn about it, not to criticize it. The use of opioids is a very controversial area. And why is it controversial? Because unfortunately, the opioids have been abused by people who have nothing to do with chronic pain. So again, we'll go back to the cardiac issue. If someone decides that they get high on a calcium ion blocker and it works for the cardiac patient, would you stop the calcium ion blocker off the street, or would you stop that patient from taking it? I don't think you would ethically do that. What you would do is you would make sure that the person on the street didn't get it, but you wouldn't deny the patient getting what they need. So the poor pain patient who is legitimately ill is denied something based on the misuse of something that they need by someone else. And again, I stated categorically that the misuse and the misprescribing of any medication to a patient is unethical, and that physician needs to be censured and needs to be trained and needs to be, whatever has to be done to make that doctor safe. But that's a different question than whether opioids have a place in the treatment of chronic pain. Unfortunately, the baby has been thrown out with the water, and the sufferers again are the chronic pain patient. So we have a big gap in reality and education and the patient in the middle. And the person that's suffering the most at this time is actually the patient in the middle. Opioids are considered one of the safest drugs for pain. The majority of physicians that are treating chronic pain, especially it's quite interesting in Canada, is the most common drug prescribed is Tylenol 3. Now, acetaminophen is a very, very dangerous drug. The non-steroidal anti-inflammatories, examples being Advil, ibuprofen, naproxen, and many of these anti-inflammatories are actually very, very dangerous. The problem is there is a false security with these medications, and it really is a false security. It is again because of the media and because of the damage that has been done by the bad prescribing, I will say and agree, of many physicians, that we've come to where we are today. It's time for a cleanup, 100%. But the cleanup has to start from the top down and the bottom up. It's got to be both in order for everyone to buy into it. The problem is it's got such a bad name now that it's going to take a lot of cleaning up and a lot of educating. But the drugs that are being used presently by physicians are just as bad as the opioids. They're just as inappropriate at times. So again, it comes back to, it sounds like it's very, everyone says this education. It really is one of the areas where education would make a huge difference. No one would deny that there's a place for opioids in the treatment of pain. That would not be something that people would agree to. The problem, as I say, is that the treatments that people are using presently are so inappropriate. And it goes back again to diagnoses. You have to go back to first principles, which is, you bring your car in. He doesn't just listen to a clink clink and fix it. He has to examine it. Doctors are not examining their patients properly. They're not coming to proper conclusions, and they're not giving appropriate treatments. And I would find any doctor that does that totally inappropriate. And I dare say that if you look at many of the doctors that are prescribing the opioids, I would agree they are probably not prescribing it appropriately. So yes, I agree there is a big problem. But how do we fix it? We don't deny the appropriate patient the appropriate treatment. We try to deny the inappropriate patient the inappropriate treatment. I believe that they should fund the four wheels. That might sound going against me because they fund what I do. But I would challenge, the governments across Canada and in other countries to approach chronic pain in a way that they will get the best value for what they're actually paying for. And we know what that is. We know that multidisciplinary works, and we know it works in many other diseases. But by not giving it to the chronic pain patient, we are really wasting a lot of time and money, and that's where the abuse comes in. Because the doctor in his office, the family doctor, who's seeing 40 patients a day, of which 5 are low back pain, he hasn't got the time, he hasn't got the patience, and he hasn't got the wherewithal to actually do anything with them. With a cardiac patient, he sends them to the cardiologist. He sends them for stress testing. He does the right thing. And even in many of the centres, he can get even the multidisciplinary. Look at rheumatoid arthritis, the rheumatological diseases. There are programs in the hospital for these patients. There is not for chronic pain. So the challenge is, in the millennium, that we have to take chronic pain, respect it as a disease in and of itself. We know and we have the tools to treat it appropriately, and we have to do it. And we have to understand that opioids have a place, but we have to also understand that there are many people out there and physicians who are not appropriately treating these patients with the opioids.